We have looked into a lot of aspects of critical care, for example, say putting structures into place, process into place, resources, and quality indicators, and everything. Now it comes to the million-dollar question of like, okay, we have put things into place. How far it is affordable? How far it is affordable to a common man? As you know, that whether it's Young report or McKinsey's report saying that much percentage of people are being pushed into poverty due to spending on healthcare, especially with out of the pocket kind of spending, especially from India. So that is a very, important and a very relevant question that we have to answer. And for answering that questions and get into the economics of ICU, I am proud and privileged to introduce Dr. N. Ramakrishnan, American board certified internal medicine, critical care medicine, and sleep medicine specialist. He was indeed the first sleep medicine practicing specialist in India, went on to establish a Nitra Center for Sleep Study and Chennai Critical Care Consultants, and also has a lot of first, which is adding further to his cap. The first simulation-based teaching in India, which is the TACT Academy. And we are waiting to hear from you, sir, the platform to you, sir, Dr. Ramakrishnan.
Thank you, Dr. Babu, for the kind introduction. It's a real pleasure and honor to be in this forum. So what I would like to do in the next 15 minutes and in the interest of time would be just to give an overview on cost of intensive care, how really we analyze that. Talk a little bit about the various payer systems that are available globally and how India is and how we could look at things and how we could possibly change things. More importantly, and I think several of the earlier speakers have alluded to this, in critical care, it is not just ensuring that somebody survives. It's not just adding life to years, but what kind of quality of life do people have? How do we deal with chronic critical illness? And is it really economical or appropriate to be dealing with them? And being a CAHO forum, I think it's appropriate to also have a food for thought on, does quality accreditation really impact the overall economics and cost of critical care? This was our article published in the Indian Journal of Critical Care Medicine in 2008 on cost of intensive care and how do we look at it. Cost can be a difficult one to look at in most of our setups. Extremely varied kind of setups that we have in the critical care unit, be it academic units, large corporate hospitals and intensive care units versus smaller nursing homes. So it can be extremely different, which is why it is best to look at the cost of critical care in what we call cost blocks that we analyze. And when we look at cost blocks, the ones that we are looking at primarily are manpower as one block, consumables that we use significantly in critical care, the capital equipment, which is what most people think about. The moment we think about intensive care, the moment we think about the cost of critical care, we often think about capital equipment. And let's see if this is indeed a significant one. The estates that we use, and also maintenance and all the engineering aspects and the depreciation that go with the estates, the clinical support services that are an important anchor, and of course, the non-clinical support services as well. And when we look at the cost of intensive care as cost blocks, indeed, it is not surprising to notice that a significant cost of intensive care is indeed manpower. So it's about 44% of the total cost is likely to be contributed from the manpower costs that are involved. The second highest is probably the consumables that we are using, and then followed by equipment, the capital equipment. So it's nowhere close to the manpower costs that are involved. Also, the support services, whether it is clinical or non-clinical, and the estates, probably a much smaller contribution than the other cost blocks that we just mentioned about. Now, some of you may remember this tweet by Rahul Bose, one of the actors, on how much in a hotel a fruit platter costed him. And the fruit platter costed him 442 rupees and had 2 bananas. Now, quickly, people jumped onto this and said, are you really bananas? I mean, you paid $442, I'm sorry, rupees for a fruit instead of getting the tastiest pizza for 99 rupees. And you advertise saying, don't slip. For 442, you can actually get a whole room and not just 2 bananas. Now, why am I bringing this up here? Because the moment we think about cost, we also start comparing the cost or comparing the charges across different kind of facilities that we may be dealing with, not only within the country, but globally. We compare saying, why is the cost of intensive care different in country X versus country Y? And also, within the same country, why should it be so different across different hospitals? And that's where adding the fringe costs, and whether it is the manpower or whether it is the capital equipment or whether it is the support services, and looking at it at cost block model would make a significant impact. Now, look at this here. Expensive healthcare is not always the best healthcare. When we often look at the Western countries, including the United States, where you can see that the per capita spending is significantly high, but the average life expectancy is much, much lesser than a country like Japan that has far less per capita spending, but a much higher average life expectancy. Don't want to go into each of these countries, but as you can see, there's absolutely no correlation between how much of healthcare spending is going on and actually the life expectancy that these countries are seeing, which gives us an insight on there is probably more to it than just spending on healthcare, but we need to spend it more wisely and spend it more appropriately. When we compare the different health systems, there are different models. The most looked at, or the United States model, is the private for-profit model, where there are multiple payers. The funding is both from the private and public, because the government also has its own insurance where they are paying. And it's delivered, again, both in private hospitals and public hospitals. And in India as well, we do have this model, the private for-profit model, or the corporate hospital model, or the third-party insurance payment model is quite widespread. And as you can see, India has probably all the different kinds of healthcare system. We are not just following one system, and we are probably have a little of varied kind of models that you can see. The national health insurance model, where there's the single payment or the single funding, which is the public type, predominantly, if you think about it, the Canada and the Australia single payer model. So the government or whoever is the single insurance payer and could take care of the entire population. And here again, you can see that the US Medicare model probably fits into this, where they cover all the over 65s and also those who are on dialysis. The Ayushman Bharat model may probably be heading this way, where you're looking at single payer for a select group of the population, not the entire population. The socialized healthcare, about which we could talk forever. Is this really going to work? Is it really feasible? Is it really sustainable? Is something that the Great Britain model has been around for many years, but people question whether it is really functioning well, particularly for management of chronic diseases, for planning elective surgeries, for which there's a very, very long wait list. The same thing in the US with the Veterans Affairs model, and in India, probably the military hospitals, which offer a similar kind of a socialized system. There's also the sickness fund model, which is in a way a social insurance model, which is very regulated. And the best thing that I can think of that would fit that model is the ESI, or the employee state insurance model, where there is a certain fund that's allocated from the person's own income, and there's a contribution from the government, where they could probably be using the facilities not only for chronic health care, but also for hospitalization and critical care. So looking at this globally, is there formal health coverage for everyone? And as you can see, there's a pretty high coverage in North America, much lesser, but you can see that across Europe, across Russia. It's quite significant, much lesser in the African and some of the Asian subcontinents. The Australian model, again, has significant coverage, very similar to North America, but has a different, payer system, which is more social. Now, is universal healthcare really good? And this is something that we could debate forever. If there is something that is positive for the universal healthcare, it certainly lowers healthcare costs for an economy because it's a structured way, standardized protocol. This is what you get. This is how you pay for it. This is the medication you would get. And if this is not available, you don't get something. And, even clear restrictions on what can be used in a hospital. It forces hospitals and doctors to provide the same standard of care at a much lower cost, eliminates a lot of administrative costs by eliminating the need to deal with the private insurances, which could again, have different kind of cost models that they enforce. The cons, if I could say something, it forces healthy people to pay for others who are using the medical care. So that's the social system where the doctors love people who don't have any illness, but they still are contributing to the overall medical care for the rest of the society there. Without financial incentive, people may not be as careful with their health, and that's a possibility. And most universal health systems report long wait times, particularly for elective procedures, as I already mentioned about the United Kingdom. So this was an editorial that I wrote in Indian Journal of Critical Care Medicine in 2013, titled Critical Economics of Life and Death is Intense plus Expensive Care equal to Intensive Care. And once again, highlighting the aspect that most inpatient hospital expenditures happen in the last year of life. Almost about 1/4 to 1/3 of the expenses of Medicare in the US, which covers the elderly population, seem to happen in the last year of life. And all non-survivors spend significant proportion of their lifetime healthcare expenses in their last hospitalization. So you can see that while we may be having insurance, while there may be cost involved in healthcare for a long period of time, most of it is spent in the last hospitalization, in the last year of life. ICU personnel work much harder, and I think someone else mentioned about TIS scores. I'm sorry, it says ISS scores, but it's actually TIS score, therapeutic interventions scoring system, where we look at how many interventions are done per patient per day. And when we looked at it, it is much higher and longer for the non-survivors. So we, and Dr. Mani was focusing on this, what we need to focus is not just quality of care, but also dignity of death, and clearly understand that we cure sometimes, treat often, but comfort always. But all of this at what cost is something that we need to think. The fact that somebody is in the intensive care unit does not mean we keep doing more procedures or keep doing more and more to just prolong a life that he may not be able to keep alive. It's important to understand the length of stay. And again, I don't want to preach the choir. I mean, there's a lot of people actively involved in the NABH here. So I know that you're all very familiar with it, but I do want to mention there are models in some countries where they pay on what is called DRG, or diagnostic related groups, where a certain illness is paid at a certain cost. For example, myocardial infarction. You are expected to admit them, treat them and get them home within, let's say, X number of days, 4 or 5 days. And this is the amount that you would be paid. Now that is arrived based on cost per day, the kind of medications that are used, the kind of procedures that are used. And the moment we start thinking about different diseases and looking at them as this is what the length of stay should be, this is how the cost should be, then we force ourselves to create the standards to get the patient out on time so that the average length of stay is limited. Now, the moment we exceed the average length of stay, number one, again, in insurance-driven countries, we may not get paid. For iatrogenic complications, nosocomial infections, some of the US insurances, including the Medicare, will not cover. And therefore, it's important for us to understand that we need to enforce standards to be cost effective, avoid complications, get the patient out on time so that we could limit ourselves to the average cost that is predetermined. And here, you would be surprised to see that the cost of myocardial infarction is probably much lesser than treating somebody with organophosphorus poisoning. Why? Because the length of stay is probably higher, particularly in somebody sick enough to come into the intensive care unit for management of organophosphorus poisoning. The kind of medications we use, the longer they are on the ventilator, all of those may be adding to the cost. So I just wanted to bring in that concept that we should try to restrict or ensure that we manage the length of stay appropriately while managing patients in the ICU. Again, another editorial that we wrote in Indian Journal of Critical Care Medicine on survivorship and quality. By that we mean the quality adjusted life years in pursuit of a mirage. As the mortality rates are continuing to decline, the post-ICU follow-up and quality of life after critical illness have been a lot of focus. The post-intensive care syndrome is a huge problem. It's affecting the family and the patient. The families can develop anxiety, depression, post-traumatic stress disorder, complicated grief, all of which can impact their quality of life. And from the patient standpoint, they could develop chronic physical debility, cognitive dysfunction, and mental health problem, all of which could impact the quality of life. And therefore, a patient surviving the intensive care unit may not necessarily be experience the kind of quality of life himself, or his family may not be experiencing the same, all of which makes us wonder, are we really doing the right thing? This is the post-intensive care syndrome model where we think about positively the longevity, functionality, quality of life, independence, and we need to, from a cost standpoint, think about cost of devices used, cost of initial admission, and more importantly, cost of rehospitalization. There's a lot of focus now on caring at home, ICU care at home, which might reduce the cost a little bit, but the caregiver burden remains significant in those situations as well, which is what I addressed in my most recent editorial, which was just published last month in Indian Journal of Critical Care Medicine on chronic critical illness. Are we just adding years to life? And as I just mentioned, we can save more and more patients because of newer technologies, but it comes with a price, and these patients may have cognitive and functional restrictions. And there is a huge burden of decision making on caregivers, because caregivers wonder, is it really worth it? Is this person not going to come back to the baseline? Are we just spending for someone who's not going to be who he was earlier? And in general, this whole thing impacts the healthcare system at large as well, because these patients may have multiple readmissions. Just wanted to bring in the Pareto principle, where we also call it the 80-20 rule. A small number of people consume majority of healthcare. People with certain chronic illnesses have multiple hospitalizations, keep spending a lot, and irrespective of this model that we talked about, whether it is the private health insurance, whether it's the social model, they are the ones who are consuming majority of healthcare. Majority of healthcare needs is in the last 20% of life, which is what I mentioned, and more importantly, even in the last 1 year of life and in the last hospitalization. Interestingly, 80% of the cost of care is in the first 20% of the hospital stay, which is why, after the initial care, a lot of the times hospitals want to get the patients out quickly, because then it almost becomes like a room charge with minimal other, income from the hospital standpoint as well. However, this may not apply to chronic critical illness, because these patients, while staying in the hospital or wherever they are managed, seem to develop multiple recurrent infections, iatrogenic complications, and several other problems, which adds to the cost of care. And the question really is, who pays for it? The cost for a patient with chronic critical illness is 6-fold higher, while the mortality is also higher, and keeping them in the hospital long enough is not really probably a cost-effective option for many. So I propose this model where when we are treating patients with chronic critical illness, we look at the predisposing factors, particularly the comorbidities, and more importantly, the neurological problems that patients have that seem to predispose them to chronic critical illness, particularly if they have, for example, underlying Parkinson's disease or any other chronic neurological illness that could probably predispose them to chronic critical illness. Looking at precipitating factors, I mean, is there non-compliance of medications from the patient standpoint, or are there infections leading to acute or chronic organ failure that leads to organ support? And then the perpetuating factors, looking at malnutrition, dyselectrolytemia, iatrogenic issues, and nosocomial infections while they're in the hospital. And it would be great if we can develop a scoring system based on these predisposing, precipitating factors and perpetuating factors, and then focus on preventing chronic critical illness, prognosticating chronic critical illness, and communicating it appropriately with the patient family, and then palliative care as appropriate. Because really, whose life and money is it anyway? And again, irrespective of the system we are thinking about, the caregiver burden can be huge and it needs to be focused on. Lastly, I just wanted to mention this, like looking at quality, measuring quality and driving healthcare, particularly critical care, using the quality parameters is obviously the way forward. There's several accreditations that all of us are going through. And the focus is to provide quality care and cost-effective care. And how do you provide the cost-effective care? You need to reduce the waste, need to reduce the errors, prevent problems before they happen, reduce the length of stay. Again, mixed results on that aspect in particular, depending on chronic critical illness and acute illness as well. And then looking at advanced care directives, Dr. Mani had a very beautiful talk on end-of-life care. We are often hesitant to talk about this to the family, and the cost of care can actually influence decisions. We've had some very difficult moments with family where we may feel that we may save the patient, or we may feel that the patient may not survive. And when we open up to them, families sometimes bring up the cost of care, influencing the decision on whether they want to continue care in the ICU. And while in the ICU, and again, we talked about quality several times before during this entire forum. So I just wanted to mention again that think about hospital-acquired infections. Dr. Ramasubramanian talked about infection control. It's a huge cost burden for hospitalized patients, particularly critically ill patients. So stopping those infections is certainly in our hands, and it will reduce the length of stay and the overall cost of care. Again, we can debate on who pays for the infection control measures, but that some of it was addressed by Dr. Ramasubramanian. I will not get into it. Think of it again in the cost block model. Like more you prevent the infections, the more you prevent complications in the ICU. Each one of these cost blocks may significantly come down and overall impact the cost of care, which is why quality-driven care is absolutely important. I will close with saying that ICU care, critical care needs to be patient-centered, needs to be process-oriented, evidence-based, quality and performance-focused, and not to forget, be cost-effective. Thank you.
Thank you, sir. Thank you, sir. Thank you for giving us a bird's eye view about the economics of ICU care, right from the cost block model to trying to answer the most difficult question. I mean, like when the decision has to be taken, and how being transparent with the relatives and the caregivers can help us to take those kind of decisions, especially where in a kind of India wherein there is a different payer model which is provided. Of course, the slide was very, very educative. In a single slide, you have captured the various different aspects of a payer model, and saying that India is, it's a place for a million religions, million races, and like million payers model as well. We have every best thing under the sun. Thank you very much.